Hello students, welcome to BSN 720, Endocrine and Metabolic Emergencies. As we know, our endocrine system plays a role in reproduction, growth and development, maintaining homeostasis, sexual reproduction, responding to emergency demands of the body. So the disorders you're going to see today is based on all the metabolic and endocrine emergencies. You have already learned about the structure and function of endocrine system, as we know that the thalamus, hypothalamus, and the pituitary gland are the regulatory organs which controls the hormone production of almost all the endocrine glands in the body. It's really important that we understand this lock and key model of biochemical reactions in our body. So all hormones has got receptors on the cells, and these hormones will only attach to the cells with that particular receptor. So this explains the functioning of hormones in the body. I want you to review your BSN 420 pituitary gland abnormalities and have a basic understanding about it. We're going to look at the emergencies of thyroid gland. So you've already learned about hypo and hyperthyroidism and hyperparathyroidism. What we're going to learn is the extreme spectrum of that. So if we look at a patient, they can be in euthyroid state, that means normal thyroid hormone levels, and they can be in hyper or hypothyroidism. And the extreme conditions or the very acute conditions of that is thyrotoxicosis, and when hypothyroidism becomes severe, the patient go into myxedema coma. And that's what we're going to learn today. So what is thyrotoxicosis? This is a result of very high levels of thyroid hormones in the body. So as a result of thyroiditis, thyrotoxicosis can happen as an emergency response in the body with or without hyperthyroidism. And it's called thyroid storm or thyrotoxicosis. It is a life-threatening condition if we don't treat it. So stressors like infection, trauma, surgery, or patient with pre-existing hyperthyroidism which is not treated properly, in those patients, there could be a rapid increase in the serum thyroid levels. What happens with this is that this rapid increase in the thyroid hormone, serum thyroid hormone level, will activate more binding sites for epinephrine and norepinephrine in the body. So as a result, the heart and the nervous tissues become activated. That means the body go into a sympathetic nervous system stimulation or activation. So those are the signs and symptoms we see as a result of severe hyperthyroidism. Patient will have severe tachycardia. As we know, the autonomous nervous system is divided into sympathetic and parasympathetic nervous system. So sympathetic nervous system activation means the fight or flight response. So that's what happens in the body. Severe tachycardia, heart failure, shock, hyperthermia, usually the temperature is about 40 degrees centigrade, restlessness, agitation, increased GI motility, which causes pain, nausea, vomiting, diarrhea. Eventually, patient go into a state of delirium and coma. So the diagnosis of this condition is basically by checking the thyroid stimulating hormone levels. So when there is primary disease of the thyroid gland, thyroid stimulating hormone will be low. And in case of pituitary or hypothalamic conditions, there is not even enough thyroid hormone released by those. So depending on the cause, the TSH level might vary in the blood. Another thing you would see is high levels of T4, high levels of T3 and T4. So free T4 is the biologically active form of T4 that would be elevated. You'll also see that the ones which are bound to proteins, those levels will also be elevated. Another test is the radioactive iodine uptake test, and you see that there is like increased uptake of about 35 to 90% versus simple thyroiditis. There is only like 20% uptake of radioactive iodine. So as we see that the activity of the gland is increased. Management for this condition is usually patients are admitted to critical care unit if they are in thyrotoxicosis or thyroid storm. Medications that block thyroid hormone production is one of the treatment for this. Medications that block thyroid hormones, some of the examples are like iodine, which inhibit the T3 and T4 synthesis, which blocks the release of hormones. So iodine is used as a blocker. Another anti-thyroid medications which we usually use are propylthiouracil, carbimazole, methimazole. All these medications are thyroid blockers. One of the things we should know as nurses is that with the initiation of the treatment, it doesn't work right away. It might take up to 1 to 2 weeks for the medications to kick in, and sometimes it takes up to 4 to 8 weeks to see good results. So as soon as we give these medication, it's not going to give us a result right away. So supportive management is more important during that time period, but it eventually will start working in a week or two. We'll see, you'll start seeing differences during that time period. Uh, Important nursing intervention is that when patients are on iodide medications, advise them to not use over-the-counter medications which contain high iodine, like cough medications, expectorants, bronchodilator, salt substitutes. All of that has a high level of iodide in it, and when we are giving iodide medication, that will increase that and can cause goiter or hypothyroidism in patients. So we to be cautious about that. Radioactive iodide therapy is another treatment which destroys that overactive thyroid cells, so thereby reducing the thyroid hormone levels. Other management include reduction of sympathetic nervous system activity by sympathetic nervous system blockers, which are beta blockers. As we know, sympathetic nervous system has alpha and beta receptors. So beta blockers are a category of medication which can reduce the sympathetic nervous system symptoms, which is like hypertension, tachycardia, etc., are treated with beta blockers. Then monitoring for cardiac arrhythmias and decompensation. Supportive therapy is basically directed at managing respiratory systems, so avoiding respiratory distress, providing oxygen. If patient has hyperthermia, treating that, administering IV fluids to replace that fluid electrolyte imbalance. So those are some of the primary management of this. We also should provide adequate rest because they are in a hypermetabolic state because of high thyroid hormones, and maintain nutritional balance by giving high calorie diet. So we're looking at high calorie diet, about 4,000 to 5,000 calories per day, and most of the calories are coming from high protein, high carbohydrate diet. So those are some of the nursing interventions you should keep in mind. And also, ask patient to avoid things like stimulants, example coffee, which can stimulate them. So any stimulants should be avoided. That's the basic management of hyperthyroidism. Let's look at next condition. Oh, again, with the patients might have exophthalmos, so that is protrusion of the eyeball. So nursing care is also focused on caring for that, like applying artificial tears to reduce the cracking of the conjunctival membrane, reducing periorbital edema by reducing salt. And then elevating the head of the bed. You can provide them with dark glasses, lightly taping the eyelids to help shut it during sleep. Teach patient to maintain flexibility by doing those intraocular muscle exercises, so that could help also strengthen the muscles. So those are some of the management caring for the discomfort with the eyes. Now, next condition is myxedema. Myxedema is a severe form of hypothyroidism. It can cause something called myxedema coma. So basically, there is edema or swelling of hands, face, feet, periorbital tissues. And in severe cases, patients can go into a myxedema coma. This condition is precipitated by either it could be as a result of infection or certain drugs, like patients with hypothyroidism, when they take excessive of drugs like opioids, tranquilizers, barbiturates, all of that can precipitate myxedema coma in patients. Or extreme exposure to cold or any trauma or any stressful condition in the body can actually precipitate this. So it's characterized by subnormal temperature, hypotension, hypoventilation. So just opposite of the sympathetic nervous system stimulation. Treatment or management is by supporting the vital functions and replacing IV fluids and IV thyroid hormone replacement. Now, the thyroid hormones, which we usually use, is levothyroxine. So in elderly patients, if we are administering levothyroxine, as a general rule, it is started as a lower dose and then titrate up if the patient can tolerate it. And again, levothyroxine also, it might take up to 4 to 6 weeks to have full good results. And during that management, nurse should also monitor for myocardial ischemia or angina, tachycardia. So we usually ask patients to check their heart rate when they are on thyroid replacement. And if their heart rate is above 100, to report it to their primary care provider, or if they have any signs of chest pain, angina, myocardial infarction, get medical attention right away, because this treatment can induce myocardial angina in patients. So this is something we should always educate patients from an NCLEX perspective and also in your practice. Next is about the adrenal glands. As we know, it has two parts, medulla and cortex, and you've already learned about the conditions like Cushing's syndrome and Addison's disease in BSN 420, so I want you to go and review that. Now, if we look at the gland itself, it's situated right on top of the kidneys. It has got two parts, adrenal cortex and adrenal medulla. The medulla secretes epinephrine and norepinephrine. The cortex secretes all of those hormones, the mineralocorticoids, glucocorticoids, and the androgens. It has three layers. The outermost layer is the zona glomerulosa, between is the fasciculata, and innermost is the reticularis. So all of these layers secrete different kind of hormones. Now, one of the extremes of the condition is Addison's crisis, which is a medical emergency and it can be life-threatening. A lot of people with Addison's disease die abruptly as a result of Addison's crisis. It is caused by insufficient adrenocortical hormones or a sudden sharp decrease in the hormones. So let's see what are the causes for this. It could be triggered by stress. Whenever our body goes through stress, we have more demand for the cortical hormones. So infection, surgery, trauma, hemorrhage, any psychosocial or psychological stresses can cause an increased demand for the hormone. Sometimes sudden withdrawal of corticosteroid hormone therapy can also put the patient into Addison's crisis. So one of the nursing responsibilities when your patients are on steroid treatment is that you don't abruptly stop the treatment. It's always tapered and stopped. That gives the body time to recover from that withdrawal of the hormone. That's one important thing you should know. This is one of the favorite NCLEX questions you might hear, how to, when a patient is saying that, oh, I stopped taking my corticosteroids, which was given for my asthma. You should advise them not to stop it abruptly, just to taper it down as per the physician's instructions. Any adrenal surgery where this gland is removed, or whenever there is pituitary gland destruction in case of radiation treatment to the brain. It could damage the pituitary gland, so the secretions decreases. So clinical manifestations of this are glucocorticoid and mineralocorticoid deficiency is what we're going to see, which include hypotension, especially postural hypotension, tachycardia, dehydration, hyponatremia, and hyperkalemia. It's important that you note it's hyponatremia. Sodium level will go down and the potassium level will go up. So patients in Addison's crisis usually go into cardiac arrest because of this hyperkalemia. They also are hypoglycemic, fever, weakness, confusion, all of the signs are seen. Hypotension may also lead to hypovolemic shock. GI manifestations include nausea, vomiting, diarrhea, abdominal pain, lower back pain, etc. So diagnostic studies, how do we find out if there is any problem with the adrenal glands? We do this adrenocorticotropic hormone challenge test. So we administer a dose of ACTH and see if the adrenal gland is responding. If it is not responding, what does that mean? Is that there is a primary adrenal gland dysfunction. Or if it's responding means there is no problem with the adrenal glands, it is a pituitary or hypothalamus problem. So that's how we differentiate between the two. And then serum levels of potassium, chloride, sodium, etc. are monitored to see if there is hyperkalemia or hyponatremia or hypoglycemia. And these serum abnormalities are usually also associated with Addison's disease. Urine levels will show less amount of cortisol or aldosterone levels. ECG changes might occur as a result of hyperkalemia. We could see T waves are peaked. CT or MRI shows if there is any calcification or tumor in that adrenal gland. So management is, because it is a life-threatening emergency, shock management is what we implement here. Also ABCs, give high dose of hydrocortisone IV, then fluid replacement, especially saline. 5% dextrose is also given because the patient is hypoglycemic. So watch for hypotension and electrolyte imbalance until the blood pressure is normal, and also for cardiac arrhythmias. We don't usually give hypotonic solutions because that can worsen hypernatremia. So whenever your patient has so low sodium level, avoid using hypotonic solutions. Interprofessional care basically involve replacement of that hydrocortisone. So before talking about that, I wanted to show you something. You might have already learned this in your physiology, that in our body, early morning around this 8 to 12 is the peaking of the cortisol levels, and then it kind of balances off into a lower level. So when we are replacing this fluids or medications, so sorry, when we're giving hydrocortisone, we always give 2/3 of the dose in the morning and give the other 1/3 in the afternoon. This is one of the favorite NCLEX questions. Make sure that you learn it. And then other replacement therapies include glucocorticoid replacements, different type of hormone replacement. Uh, we advise patients who are with Addison's disease to take salt additives, especially this is your patient education question. They might ask you, your patient with Addison's disease want to run a marathon. How would you give patient advice? So tell them like if they're stressing their body out, to take a lot of snacks with high salt in it, drink a lot of water, keep well hydrated so their body doesn't go into crisis or hyponatremia. So these are some of the tricky questions you will get. Noticing changes in blood pressure, weight gain. These are all symptoms of Cushing syndrome. So that means there is excessive hormones, or as a result of the treatment, patient could develop Cushing syndrome. Now, protecting them from infections or asking them to get their vaccinated, or extremes of temperature, are all avoiding stressors and cope better so that their body doesn't go into Addison's crisis. So that is about Addison's disease. Next one is diabetes. So you've already learned about diabetes in your 420. Now we're going to look at the complications, acute complications of diabetes. So first one is diabetic ketoacidosis, then hyperosmolar hyperglycemic syndrome, and hypoglycemia are the three acute complications of diabetes mellitus. Let's look at diabetic ketoacidosis. This is usually seen in patients with primary type 1 diabetes, that there is a deficiency of insulin. So which is characterized by hyperglycemia, ketosis, acidosis, and dehydration. Let's look at the next picture, which gives us a bit of the pathophysiology of the disease condition. So whenever there is deficiency of insulin, which is secreted by the beta cells of the islets of Langerhans of the pancreas, so there is less insulin in the body, so glucose is not metabolized. What happens next is fat metabolism happens. Fat breaks down for energy. Glucose cannot be used for energy in this case because of insulin deficiency. So fat is utilized for energy. The end product of fat metabolism is ketones. So as a result of ketones, the pH of the blood decreases, and also body go into a state of acidosis. Again, which also causes the protein to break down. So the liver convert proteins or the amino acids into glucose, because they cannot use the glucose which is in the body because of the deficiency of insulin. So they're depending on other factors like fat and proteins to increase the energy. So all of this causes increased glucose in the blood, because here liver is doing gluconeogenesis, which is formation of glucose using proteins or amino acids. Other parts of the body, because glucose cannot be used for energy, we're using fat stores for energy, and that breakdown causes ketosis and acidosis in the body. So in general, the glucose level increases, there is excessive ketones in the body, the pH alters, or it causes metabolic acidosis. This increase in the blood glucose level or hyperglycemia can also affect the kidneys. So it causes kidneys to secrete more urine, or it causes polyuria. It increases the urinary output. It also excretes the potassium, sodium, all those ions out of the body. So in a nutshell, it causes hyperglycemia, hypokalemia, and hyponatremia in the body. Also, the H plus ions, or the acidotic ions present in the body, gets into the cells. As a result, potassium goes out of the cells. So at an intracellular level and an intravascular level, the potassium level become low. So that is a basic pathophysiologic change which happens with diabetic ketoacidosis. Signs and symptoms of DKA include polyuria, polydipsia, dehydration, poor skin turgor, dry mucous membrane, tachycardia, orthostatic hypotension, lethargy, and weakness. All of this is because of the fluid electrolyte imbalance. In severe dehydration, the skin becomes loose and dry, eyes look sunken, nausea, vomiting occurs, abdominal pain happens, dehydration of the muscle tissue. Now, muscle function is maintained by potassium. So whenever there is low muscle function, people will have muscle weakness and lethargy and all those symptoms. So that's one of the reasons. Delayed gastric emptying is also again because of reduced muscle tone of the GI tract. So all of this electrolyte imbalance causes these symptoms. It can also cause paralytic ileus. As a result of metabolic acidosis, the lungs try to compensate that by increasing the respiratory rate and depth, which is called Kussmaul's respiration. So this is to reverse metabolic acidosis. The body is trying to maintain the balance, which would be manifested as hyperventilation or Kussmaul's respiration. Patients might also have acetone, or that sweet ketotic breath or fruity smell in their breath. What are the lab findings? So, Diabetes Canada says if blood glucose is above 14 millimoles, in case of a type 1 diabetic patient, they are in diabetic ketoacidosis. Arterial blood pH drops from below 7.35. Bicarbonate levels are low. Anion gap increases. Now, you would want to know what the anion gap means. You don't have to memorize it, but just for an understanding, anion gap is the difference between the positive and the negative ions in the body. So when maintaining homeostasis, our body has perfect balance, that the number of anions and cations are same. But in our blood, there are certain unaccounted cations and anions. So normal range is 3 to 11 millimoles per liter. And if it is too low, below 3, it's dangerous. And if it's above 11, it becomes dangerous. So in certain acidosis, you will see that the anion gap increases. That is more than 12 millimoles per liter or milliequivalents per liter. That means, so the cations are the positively charged ions, your sodium, potassium, calcium, magnesium, etc. Anions are the chloride, bicarbonate, phosphate, etc. Plus, some of the cations are like products of protein metabolism. Some of the anions include albumin, etc. So whenever there is acidosis, there is more H plus ions in the body, which causes a disruption in this anion gap. So just to know, the anion gap is the difference between the cation and the anions in the body. Usually it is same number. That is anions, the cations minus anions should be 0. But there are certain unaccounted metabolic waste, protein products, albumin, etc. in the body, which we don't really count. So we allow, when we calculate this gap, we allow like 3 to 11 as a normal range. But ideally in the body, the number of ions are the same. with the uncalculated ones, we give them a window of 3 to 11. So if one of these ions increases, example, anions increases, this 3 to 11 range changes become 12, 13, 14, etc. So if the anion gap is increasing, that means metabolic acidosis is worsening. That's what it means. You just have to have an understanding of that. And we can also see ketones in blood, in urine and blood. So that is about DKA. We're also going to look at this hyperosmolar hyperglycemic non-ketotic syndrome and then look at the management together, because it is almost similar management with slight difference. So this is a life-threatening condition. This is less common than DKA because this happens mostly in older patients with type 2 diabetes. They have enough circulating insulin. As a result of that, ketoacidosis does not occur. So their hyperglycemia become really, really high, but they don't have ketoacidosis. They don't go into metabolic acidosis as much. Because of that, there is less symptoms in the earlier stages and it's hard to diagnose. So we don't know that until sometimes patients go into this hyperosmolar hyperglycemic state and go into a coma. Again, lab results for show blood glucose of more than 34 millimoles per liter, increase in serum osmolality as a result of this high glucose level, absence or no ketone bodies. And if we don't treat this, patient will go into severe dehydration and electrolyte imbalance, cerebral edema, and all those problems and die. Let's look at the differentiation table between the two. So DKA is usually seen in type 1, rarely seen in type 2. This is usually occurs in type 2 diabetes and in elderly patients. DKA is rapid onset. The hyperglycemic hyperosmolar non-ketotic syndrome, it is of slower onset and we sometimes misses the symptoms. Blood glucose levels 14 millimoles in high. This is usually 34 or 33. They are usually acidotic, but in this one, the pH levels might be normal. High osmolality. Bicarbonate levels are low in DKA because it's an acidotic condition. So as the bicarbonate, which are the alkaline component, this become lower and lower when patient go into acidosis. But here the plasma bicarbonate level is normal. This is high mortality rate because we misses the diagnosis. So emergency management in any coma patients is make sure of patent airway, establish IV access, administer IV sodium bicarbonate if there is severe acidosis, administer oxygen, replacement of electrolyte, especially to treat hypokalemia, and then regular insulin is given as a drip. So the only insulin which is given as IV is regular insulin. And usually go with the drip rate of 0.1 units per kilogram per hour. So it's given as a continuous infusion. When we do as a continuous infusion, one of the important things or nursing responsibility is to watch for electrolyte shift. The role of insulin is to move sugar into the blood. Sugar into the cells, glucose into the cells. That is a function of insulin. When that is an active process, energy is utilized. When that active transport across the cell happens, potassium also moves into the cell as a passive transport. So imagine glucose and potassium are best pals. When insulin moves glucose into the cells, potassium go with glucose into the cell. As a result, patient will have severe hypokalemia. So what you're watching for is severe hypokalemia in patients. And then fluid resuscitation, maintain urinary output about 30 to 60 mLs per hour. Once we reach this value, when blood glucose levels are 14 millimoles per liter, you do not give them just insulin drip. because if the blood glucose level drops rapidly, it can cause cerebral edema and neurologic dysfunction. For that reason, when we reach the blood glucose level at 14 millimoles per liter, we add dextrose to the IV fluid to prevent sudden hypoglycemia. So sudden hypoglycemia can cause cerebral edema and neurologic damage. For that reason, you will see that until 14 millimoles, we will give like insulin in normal saline as an infusion. But as soon as we hit that value, we add dextrose to that IV fluid just to bring it down cautiously. So that's one of the most important nursing responsibility while administering IV insulin. Then electrolytes are monitored very closely. We do cardiac monitoring to see if they have any cardiac arrhythmias as a result of hypokalemia. Ongoing monitoring when we replace fluid is to assess for breath sounds to catch fluid volume overload in the beginning. Serum glucose, pH, and potassium levels are very closely monitored. Usually organizations have a protocol to follow every hour or every 2 hours, watch for that at certain levels. Then also watch for vital signs, level of consciousness, cardiac rhythm, oxygen saturation, and urine output very closely. And we also might replace IV potassium in this case. Now, potential complications are fluid volume overload. So you're going to watch for their overload symptoms like pulmonary edema, heart failure, etc. Intake and output is measured. IV is administered with electrolytes as prescribed, and watch closely for any electrolyte imbalance. Next thing is hypokalemia. Hypokalemia is one of the serious complications of insulin therapy. We always watch patients' potassium levels very closely and also cardiac monitoring to catch that at an earlier stage. Patient could go into hypoglycemia when we overcorrect this, or they could have a cerebral edema as a result of rapid correction of hyperglycemia. Remember I said after 14 millimoles, we always cautiously give IV fluids and IV insulin, and also might add dextrose to prevent that sudden fluid shift across the cerebral membranes or the blood-brain barrier, which can cause cerebral edema. So watch carefully for that. Other nursing management include insulin therapy, watch for fever, hypovolemic shock, tachycardia, and Kussmaul's respiration. This is a continuous glucose monitoring system. Some patients will have that attached to them, so they can have their, especially in type 1 diabetes, they can have their blood glucose monitored and they can adjust their calories based on that. Now there are insulin pumps which will continuously administer insulin to patients. The third complication is hypoglycemia. So if the blood glucose levels are lesser than 4 millimoles per liter or 70 milligram per deciliter, we call this hypoglycemia. And this could be also a complication of diabetes, because that means we're overcorrecting the glucose levels. So in this case, whenever there is a decrease in glucose level, it activates the neuroendocrine hormones, especially the epinephrine, and it affects the autonomous nervous system. Autonomous nervous system get activated, which causes the symptoms like diaphoresis, tremors, hunger, palpitations, tachycardia, etc. And also it affects the cognitive functioning, and patients can go into confusion and coma as a result of hypoglycemia, because our brain needs glucose for functioning. So the levels go down, the neurologic functions also go down. Manifestations of hypoglycemia can mimic alcohol intoxication, so we misunderstand that for that. Certain patients might not have some of these symptoms. They become asymptomatic, mostly because of autonomic neuropathy. So patients develop neuropathy as a result of complication of diabetes. So in those patients, some of the hypoglycemic symptoms does not manifest. Especially it occurs in older patients. Patients who are on beta blockers are another category of patients who probably won't have any symptoms of hypoglycemia. That's because remember that sympathetic nervous system has got alpha and beta receptors. So we're blocking it with the medication. That's the beta blocker medication. So their symptom manifestation will be lesser. So we don't really, so if a diabetic patient who is on beta blockers for hypertension, they probably won't have those symptoms right away. So that should be something you always keep in your mind. So as soon as the patient is diagnosed with hypoglycemia, we need to correct it. In mild to moderate case, and when the patient is alert and they can tolerate oral food, you usually give the fast-acting carbohydrate or fruit juices or like dextrose tablet, any of these oral preparation to counteract hypoglycemia, and then recheck blood glucose within 15 minutes. No improvement, we give the exact same treatment again until their blood sugar levels comes up. You can also give them additional snacks for long-acting combination like protein and carbohydrate, like crackers with peanut butter or cheese. Those are like more complex carbohydrate and protein, which also help to maintain the sugar level. Instead of giving them too much fruit juices, it's recommended to use some complex carbohydrate plus protein or fat. So it actually is longer acting combination. So if you have an NCLEX question asking what is a good snack for a diabetic patient, it's not just fruit juices. It might be a better combination is like peanut butter and cracker or bread and peanut butter or something like that with protein or fat in it. So in unconscious patients, they cannot take anything orally, then you have to give IV dextrose. We usually give 50% dextrose, 25 to 50 mLs in 1 to 3 minutes. And then check the blood sugar level repeatedly. And also we can give IV or IM injection or subcutaneous injection of glucagon. So insulin and glucagon are the two hormones produced by pancreas. Insulin reduces the blood sugar level, glucagon increases the blood sugar level. So we're giving glucagon to increase the blood sugar level in patients. Oh, there are two questions. So cardiac monitoring is initiated for a patient in diabetic ketoacidosis. The nurse recognizes that this measure is important to identify which of these options among 1 to 4. Number 1 is the answer. It is to find out if there is any dysrhythmias occurring as a result of hypocalcemia. Another question, patient with type 1 diabetes called the clinic with symptoms of nausea, vomiting, and diarrhea. Which information should the nurse give the patient? And the correct answer is to check their blood glucose level every 2 to 4 hours because this patient could go into hypoglycemia. That is the end of this session.